They're trying to preserve the spleen. Okay, so here's a case. We're going down through the CT. You can see that there's severe hydronephrosis on the right. And we're starting to get into this retroperitoneal soft tissue. You can see the aorta is actually getting narrowed. So that was the aorta there, and it's getting narrowed and pushed aside. And then the iliac arteries are coming out. I don't really see a normal inferior vena cava, and we do have retroperitoneal fibrosis. So anyone want to talk any differential for this kind of tissue?
Retroperinal fibrosis, extramedullary hematopoiesis.
Yep, good. So yeah, we thought about RPF immediately. This patient, you can see that they have a diversion. They have a large peristomal hernia. Somebody wrote in treated lymphoma. That's a good thought too.
IgG4.
Softer. Yep. So the retroperitoneal fibrosis can be related to IgG4 or in this case, this patient had a history of endometrial cancer. And so we were worried about malignant, adenopathy. So we did a biopsy. And so one of the things we did was basically we charted out our route, planned it out based on like where the calcifications of the aorta were, but then we also gave contrast as we got closer to make sure that we were kind of pointing away from the aorta. You can see we're a little close, but basically, we would tip our needle down and get into this tissue. So we got core biopsies, and this was metastatic endometrial cancer. Two of the points I wanted to make, because that were coming up, for example, from the fellows when we were doing this biopsy was, well, how do we know we're not going to hit the IVC or the ureter? And basically, this is all tumor at this point. The IVC is obliterated. So we have biopsied this kind of situation, many times before and not encountered any bleeding. So my impression is that the IVC kind of is gone at this point. This is all tumor, and you can safely biopsy this. Same thing with the ureter. This ureter, this extent of tumor. Obviously, if it was just a small lesion only involving the ureter, that would be different. But this extent of tissue is not going to injure the ureter because the ureter at this point is not coming back.
So you can also safely do trans-IVC biopsies. IVC is a low pressure system, so the bleeding would be also very well contained in retroperitoneum.
Thank you, Olga. It's awesome to have you on. Olga is from BI, and she's like an interventional expert, and I'm glad she's here to give her expertise. That's also come up with us, for example, like an IVC leiomyosarcoma. Sometimes, for example, you can see the IVC, you see the leiomyosarcoma hanging off one wall of it. We've also done those biopsies. And so basically, technically, we are going through the wall of the IVC. But I'd pick the side, obviously, that the tumor is hanging off of. So Olga, I have a question for you. When you say you can go trans IVC, some of my IR colleagues have told me that here. Does that mean, for example, say you had a tricky tumor that was like in the aortocaval region and you didn't have a path except for going through the IVC? Would you go through the IVC in that case? And secondly, what gauge of needle would you use?
Yes, you can do transcaval biopsies. Basically, we routinely use 17-18 system, 17 coaxial, 18 gauge biopsy. In those cases, I would try to go as much as possible through the psoas muscle, just because it will give you tamponade much more, a little bit more safety as you go through if there is some sort of residual bleeding. But regardless, again, IVC is a low pressure system, so it will just tamponade in there.
For example, like some of my surgeons have said, like if they get a tear in the IVC, like suddenly the entire abdomen could like well up with blood. Is that because the tear is like much bigger than?
Well, so first of all, this is a very small gauge system, relatively. Big tear is big tear, but so there are a lot of IVC filter retrievals that been there for ages, and when they try to take it out, you obviously tear some little bit of the wall. And there's no significant bleeding and encountered.
Okay,
one more. Vast majority of the cases. Just one historical kind of correlate. The angiography started as translumbar aortography. So they would put a huge needle through the psoas into the aorta, and patients would not die. So obviously we're not doing this anymore, but going through the muscle into the retroperitoneum is usually provides sufficient tamponade.
Okay, awesome. I have one more question for you because this has come up with us before. So say you see a central liver mass and it's kind of tricky for us to get to, it's like next to the hepatic veins. What is the feasibility of doing a transjugular liver biopsy of like that liver mass, and what like gauge cores do you get when you do that?
So it's extremely difficult to target through the transjugular liver biopsy. Your directionality is very, very limited. You can try to do it. Obviously, you try to do tips. Sometimes there's European approach to tips is combined, basically do transjugular approach and then you ultrasound abdomen and you're trying to direct your needle kind of, so you have two operators. So you can try to do that, but it's very, very tricky. The cores from the transjugular liver biopsy are actually not great because again, it's a very long system in the type of the needle. So ideally you would I would do it percutaneously.